Thank you, Chairman, ladies, gentlemen, colleagues. My background is as a GP, and I've also been the chairman of the Swedish Medical Association for Family Medicine for 5 years, and served as quality controller for the Swedish Society of Medicine concerning healthcare centers. Thus, I've seen the brain drainage and professional isolation in primary health care. To counteract my own brain drain, I moved to university, where I today served as a professor in public health and also interested in applied health technology. Thus, I tried to counteract this brain drain. This session will be about stakeholder involvement. When planning for the Prime Care IT project, the importance of stakeholder involvement was highlighted, and a specific work package on this was applied for in the project application. I have been in the lead of this work package, and today I'm going to present how we have worked to involve stakeholders during the project time. I'm going to follow this agenda. First, I will present out our aim. Then I present the procedure of, and the results, policy analysis, stakeholder lists, stakeholder events, and stakeholder discussions and statements. Thus, the procedure has been mainly in 3 steps. First, stakeholder analysis, then different stakeholder activities and events, and finally the achievement of political statements. The aim of this project was to raise political awareness of strategies to ensure high quality and accessible service in remote primary health care by means of e-health. Especially focusing on teleconsulting and telementoring, which was applied in different pilot settings among the project partners. It could be like primary health care, consulting secondary care, and newly graduated professionals getting continuous professional development mentored by senior professionals, as you heard in previous presentations. One example, and you will hear more about other examples, could be that district's community nurses being led how to treat chronic leg ulcers by consulting a wound care center at the hospital via their telecommunication equipment and the computers. As I said, you will hear more about this in the next session. The first step in the actual analysis was to get knowledge and understanding about the healthcare systems in the Baltic Sea region. This showed us similarities, such as primary care responsibilities, how to take care of patients, when to refer them to secondary care, etc. But it also shows substantial differences to consider in the analysis, and this could be differences in healthcare organization and differences in financing. For example, almost 100% of primary care is privatized in Germany, Latvia and Estonia, but only 5 to 10% in Finland and Belarus. Sweden has during the last decade a dramatic increase of privatized primary care, and today almost 50% of the primary care in Sweden is private. Also the financing of healthcare differ, even though most countries had predominant governmental tax financing. And when we have understanding of these contextual factors, we did the actor and stakeholder analysis. So based on the contextual factors, the second step was to identify stakeholders on 3 levels: the national level, the regional level, and the local area. In this analysis, we also considered in the stakeholders' power and competences. Power and competences in decision-making concerning e-health implementation. This led us to identification of 7 actor and stakeholder categories on the national level and 8 categories on regional and local level. This was similar in all the participating countries. The most influential or important one was the political. On the national level, for example, ministers of health, and on the regional and local level, for example, county council politicians. I think a remarkable observation was that healthcare professionals have a very low impact, or should I say interest, in this field. The result of this actual and stakeholder analysis was the establishment of a stakeholder list, where all the individuals in the previously described levels were identified by name, position, and the way how to contact them. And also, we have considered the power and the influence on decision-making. This list was created by regional stakeholder contact persons from the project partners among prime care ITs participating countries. You can see them on this list. These persons had also the responsibility to regularly update the list during the project time. If a minister was replaced, or if a director of a hospital was replaced or something like that, we would get a new name for this. They even have the responsibility to collect information about different events and activities where the Prime Care ET project was presented and discussed. They were also able to inform about the project upon a request and distribute newsletter produced during the project. Events could be national or regional conferences, workshops, but could also be personal meetings with the stakeholders. So every such event should be documented and collected. And this created a stakeholder event list that has been one of the outputs in the project. During these stakeholder events, we discussed 3 main objectives. The first one was to assess regional needs and strategic opportunities, as well as barriers of teleconsulting and telementoring as tools to avoid professional isolation and brain drain. The second, implementation of pilot sites. And the third, to discuss how to prepare the durability and expansion of these pilot solutions. The main results and achievements of the project that was presented to the stakeholders was that teleconsulting and telementoring gave opportunities to the healthcare professionals in remote areas for professional guidance, knowledge, and networking. It showed possible solutions to counteract brain drain and professional isolation. problems that were relevant in all participating countries within the Baltic Sea region. In addition, we also found problems with the legal acts on distance learning. You heard about this in the morning. Another result from the project we discussed with stakeholders will be the creation of transnational strategic papers concerning the project tools that could help recruiting healthcare professionals to remote primary care areas. Also, this was discussed in the roundtable discussion, as you heard in the morning session. Besides the results and achievements, 3 major challenges, or should I say barriers, to implement e-health in a wider perspective were identified and discussed with the stakeholders. These were missing IT infrastructure, missing engagement in the organizations, and lack of financial incentives. This could be a lack of high-speed broadband internet in remote areas, lack of personal's will to use something new among healthcare professionals, and how to get financial reimbursement for service provided. These challenges must be met in the future to get a wider spread of these e-health solutions. To conclude the project's result, I see the implementation of new technology, e-health, exampled here by telementoring and teleconsulting, as a paradigm shift for the healthcare professionals. That is why large-scale implementations seems unsuccessful. Instead, implementation must be built on and being expanded by good examples and pilot projects, such in this project. The future, also in my opinion, will be a more patient-driven, focused healthcare. And we have been working with the stakeholders to get an understanding on this. So the last slide in my presentation will symbolize the final outcome of the stakeholder involvements in the Prime Care IT project, since the project is coming to an end, the 28th of March. This is the signing of stakeholder statements from different levels among the participating Baltic Sea region countries, where they state to take in consideration the good practices and recommendations of the Prime Care IT project. We have received some of these statements the last weeks, and we intend to get such statements from all the participating countries and are in good hope of achieving that as well. Thank you.